Hello and welcome everyone to this e-seminar dedicated to genetics and CKD, co-organized by the Genes and Kidney Working Group of the ERA and the European Society of Pediatric Nephrology. I am Emilie Cornec-Le Gall. I am a nephrologist from Brest, France, and the vice chair of the GNK Working Group. I am extremely happy to moderate this e-seminar, which brings together pediatric and adult nephrologists. In the past few years, we have finally realized that there is, of course, no frontier between pediatric and adult onset inherited kidney disease. And the progress of genetics have shown us that so-called pediatric diseases can be diagnosed in adulthood. Adult onset diseases are often diagnosed earlier than before in the context of new therapeutic options. This calls in every center for more interactions on a daily basis between pediatric and adult nephrologists. We are extremely lucky to have two top experts in the field today. Professor Rachel Lennon is a pediatric nephrologist and researcher from Manchester, UK, and an expert in inherited kidney diseases, particularly Alport syndrome. Professor Jan Halbritter is an adult nephrologist and researcher from Berlin, Germany, with a strong involvement in nephrogenetics and rare kidney diseases. The two presentations will last 15 to 20 minutes each and will be followed by round discussions with our two non less excellent panelists. Professor Max Liebau from Cologne, Germany, is a pediatric nephrologist and the chair of the ESPN Working Group Inherited Kidney Diseases. And Professor Torra from Barcelona is an adult nephrologist and an expert in inherited kidney diseases, notably Alport and ADPKD. We would like to encourage you to interact by posting questions in the Q&A. And without further ado, I would like to invite Rachel Lennon to give us a pediatric nephrologist perspective on genetics and CKD. Rachel, thank you.
Thank you, Emilie, for the very kind introduction. And as you say, it's fantastic to be joined up with pediatrics and adult perspectives on the seminar today. So yes, as Emilie said, I'm a pediatric nephrologist and clinician scientist. I'm based in Manchester in the UK, clinical practice at the Children's Hospital. And then I lead a research group and centre based at the University of Manchester, where we've got a big interest in extracellular matrix, so the Wellcome Centre for Cell Matrix Research there. And I also have a research and clinical interest in Alport syndrome, and we recently set up a hub based in Manchester for progressing both preclinical studies and genetic studies in Alport syndrome. So that's my kind of background. For this talk in 15 minutes, that's really hard to cover the breadth of genetic kidney disease in children and young people. But I guess broadly, we can think about that in the compartments of the nephron, glomerular disorders, and I've highlighted, I guess, the three key ones that we are thinking about and challenged with in pediatrics. So the early onset congenital and steroid resistant nephrotic syndromes, persistent proteinuria and hematuria phenotypes. And then in tubular disorders, I think top of the list in terms of frequency would be those that come into cystic kidney disease, and of course in the earlier stages of life, the challenges that we have with the more severe early onset tubular disorders. So I'm going to highlight, because I think that's the only thing you can do in 15 minutes, highlight some of the examples that I'm perhaps more equipped to speak about, but use those as examples of how we're really starting to learn a lot more about genetic kidney disease in children and young people. And one of the reviews that I'll show you, I think on the next slide also, made this statement in the abstract. This was a review in the Lancet a few years back now from Olivier de Vuist and Franz Schaeffer and colleagues. And actually this statement that is just at the bottom of the slide, almost all children and young people that require dialysis and transplantation will have an underlying genetic disorder. And so that certainly highlights the need for us as pediatric nephrologists to consider genetic testing in those children and their families. So here's the review I mentioned, just the PubMed ID there at the bottom of the screen, and this nicely kind of arranges genetic disorders according to the segment of the nephron, and so a whole host of glomerular disorders, those that are affecting the proximal tubule, including cystinosis that we'll see presenting early in infancy, the thick ascending limb, Barter's included in there, and then the disorders that are predominantly affecting the collecting duct, with those more rare tubular disorders. So just adapting that slide a little bit, then these are the ones that I'll focus on in the next 10 minutes or so, and that's just to highlight how the gene discovery has really improved what we now understand about those glomerular phenotypes, in particular congenital nephrotic syndrome and persistent proteinuria. And I'll use as the main example there to highlight where we are with clinical and genetic practice in pediatrics. I'll highlight the type 4 collagen genes that cause Alport syndrome and that widening spectrum of kidney phenotypes. Of course, we have in the proximal tubule a whole series of genetic disorders. And I guess the one point that I wanted to highlight, I'm not going to go into further detail about these proximal tubular disorders, but I just wanted to highlight the importance of considering tubular proteinuria when we get those elevated albumin-creatinine ratios back from urine testing. Although it feels, I think, in certainly in my clinical practice, where I perhaps do see an enriched population with glomerular phenotypes, that this is the majority. I think unless we're really carefully thinking about that early on, to consider whether this could be a tubular rather than glomerular proteinuria, it's really important to do that basic first level investigation. And I'm not going to go further into the tubular disorders, Barter and the distal RTAs, nephrogenic DI, but I guess these are probably the highlights that, you know, certainly in the practice that we see in Manchester, in the UK, these are the kind of top of the list. But I will come back to, just at the end of the presentation, that kind of broadening group of disorders that come under cystic kidney disease or ciliopathy. So here's an interesting graph on the left, which just, I think you could take any condition that we see in medicine broadly, and there'd be a similar kind of graph in terms of gene discovery from the 1990s, when technology really came to the fore to enable gene discovery. And there's just been that continual rise in the number of genes that are associated with phenotypes, and this is for genetic disorders of the filtration barrier, glomerular filtration barrier, that we documented a few years ago. So over a 10-year period from 2009, just under 30 genes, and over 80 10 years later. The diagram on the right shows you that all of the genes, so all of these 87 genes that are plotted on the outer circle, overlap in terms of the type of pathology. So that tells us that the pathology, the histopathology that we have on biopsy samples that we may be collecting will overlap. It's not going to be specific for certain genes. So that's an important message. in terms of linking those genes to particular functions, then this was one. This is what we did a few years ago, and you can not only localize these genes and their functions to particular cell types. So here's the podocyte, the endothelial cells, and the in-between, the basement membrane, so we can cluster the genes according to where they have a predominant and important function. But we can, for certain, in the podocyte, really go subcellular into genes that are affecting certain organelles, so mitochondrial genes, cytoskeletal genes, and right at the bottom there, the slit diaphragm, this really important junction between adjacent podocyte foot processes, and that's actually where the discovery started, with the identification of nephrin and subsequently podocin as causes of congenital nephrotic syndrome. And those two genes, so nephrin and podocin together with WT1, are still the largest in terms of diagnostic yield in that age group under a year of age. So and that's where genetic testing has the highest positive result in terms of glomerular phenotypes in children. Moving on to the collagen IV disorder, so that's something that I'm particularly interested in, and just to remind us that the pathology that we see in Alport syndrome, that goes from can include thin basement membranes through to these very split, irregular basement membranes with lamination, which is very typical of the phenotype in Alport syndrome. And this is caused by absence or reduced type 4 collagen, particular type of type 4 collagen, it's the alpha 3, 4, 5 network. And I show this slide because there is an overlap between what we were classifying as FSGS and Alport syndrome. So now with with genetic sequencing studies, whole exome sequencing, then we're identifying more of the collagen IV variants in cohorts of patients that had been formerly classified as having FSGS. How frequent are these disorders? Well, again, big genetic sequencing studies can give us this information. And this was a paper published in JASN just last year, and it was asking that very question: how common is Alport syndrome? And so what the authors did was they looked at over 200,000 normal individuals in the NOMAD database. So these are whole exome sequences, and then looked for variants in these type 4 collagen genes. And so they defined their criteria, the type of variant that they were looking for. And if you look over to the right of the slide, you can see the frequency there. So in this study, the frequency of the X-linked COL4A5 was just over 1 in 2,300. For the COL4A3 and A4, that was much higher at just over 1 in 100. So this suggests that these variants are common, but what it also reminds us is that it's not just the genetic test results that is important. We have to have a combined evaluation of the clinical presentation and the genetic test to really understand what the combination or what those variants mean within an individual and their families. So just let me move on to the next slide. I'm just going to very quickly switch tack and talk and mention cystic kidney disease and the ciliopathies. This is again from the Lancet review that I mentioned, and it's a big table. It tells us about the I guess the main players here in terms of phenotype, so autosomal dominant, autosomal recessive, polycystic kidney disease, and their clinical manifestations and genetic basis there. So further into that list, we've got the nephronophthosis genes and the more specific phenotypes that have these Sinulocan syndrome, Juber syndrome, Meckel, Gruber, etc., and all with varying phenotypes and genetic basis now that we're understanding far more about. And I guess the common thread amongst a lot of these cystic disorders now is how they affect the function of cilia, and so hence the term ciliopathy. In terms of there we go, just find the forward arrow again. I guess the take-home messages from that particular review was to consider these various 6 bullet points, that many of the cystic kidney diseases are multi-system disorders with extrarenal manifestations that we can look for to give us some clues, and there's an increasing number, just as with glomerular disease, there's an increasing number of genes that have been identified, and most of those prevalent cystic kidney diseases in adulthood, I'm sure Jan will come back to this, are within that group of autosomal dominant disorders. And in terms of the diagnosis, it requires, as I was saying before, a thorough clinical workup, and that combination of clinical and genetic evaluation. Utility of genetic testing, well, this was a review from a few years back now, and I think that's definitely changing. And the bottom bullet point there saying that actually we'll learn far more about these genes and their associated phenotypes with ongoing sequencing studies. There was just one question that came up that I wanted to very specifically, that we had ahead of the seminar, that I've just put in a quick slide about, but we had this just come through earlier today. How should we approach negative sequencing results? Should that be reanalysis? Should that be further testing? Well, these are my thoughts, and I'm sure we can come back to this in the panel. In terms of reanalysis, yes, that may well be warranted depending on what modality of test has been used. It may well be that there's going to be something more sensitive, but it really speaks to the importance of interacting with our genetics testing labs. And then further testing, yes. So one example here is RNA analysis, and that's certainly, there are definite reports in the context of Alport syndrome as RNA testing increasing diagnostic yield when variants haven't been identified through standard sequencing. So that was just a quick response to that question. And then just to finish up, I just wanted to highlight this opportunity. So if you'd like to learn more in an ongoing manner, then there is a huge gene curation effort that is running through the Broad Institute, and many of us are connected into various gene curation panels, and they cover glomerular, cystic, tubular, complement, CACUT areas. And so I chair the glomerular group, and we get on a Zoom call either every month or sometimes a little bit more frequently, 1 hour meeting, and we go through gene by gene to look at the evidence for association and causation with different kidney phenotypes. And it's a fantastic way to learn more about genetics, and you don't need to have expertise, you get training on the job. So if you fancy joining that initiative, then just drop me an email. My email's just at the bottom of the slide. So I've probably run over a bit of time there, but that's my go at the pediatric perspective, and I'm going to stop sharing and hand over directly to Jan, who's going to pick up with the adult perspective.
Yeah, thank you very much, Rachel, for your nice first presentation. That makes it much easier for me. So I hope you see the screen in the right way. Okay. Yeah, so my name is Jan Halbritter. I'm from Berlin in Germany, and I'm heading the Center of Rare Kidney Diseases in adult nephrology here. And I want to briefly, because 15 minutes, try to address this theme, genetics and CKD in adults, and from an adult nephrologist point of view. my disclosures. And I want to start out with this classic illustration of heritability of kidney disease. And you all know there is Mendelian kidney diseases, about 700 now. Syndromic diseases oftentimes with kidney manifestation. And these diseases are characterized by ultra-rare variants with a large effect size. And then on the other hand, you have complex genetic diseases that are characterized by more common variants with smaller effect size, and more typically there's an aggregate of common variants that have a certain risk for CKD. So if you want to make rough distinctions between genetic CKD in the pediatric and the adult world, I know this is all a continuum, but just to put it in categories, I wanted to highlight that in the pediatric world, we encounter much more often recessive diseases, for instance, congenital nephrotic syndrome due to nephrin mutations. And then on the other hand, in the adult world, we see a predominance of dominant inheritance. And this is interesting because here it's really worthwhile to take a family history in dominant pedigrees. Then on the other hand, single gene causality is, of course, more frequent in pediatrics, and in adults, we often see single gene causality plus environmental or complex genetics or environmental factors coming into play. Also, lower penetrance variants are, of course, more frequent in adults. For instance, the famous ApoL1 susceptibility. We less often see overt syndromic phenotypes, but oftentimes masked syndromic attenuated phenotypes, maybe due to mosaicism or others, so hypomorphic variants or non-syndromic presentations of ciliopathies like in NPHP1. I will come to this example later. And then we often see gene dosage, and whereas in the pediatric world, there's gene dosage due to gene-gene environment, in adults, it's often gene-gene and environment interplay. So I want to just highlight that in addition to this rare and common variants, there's intermediate effect variants. And we just recently learned from a publication of Eric Ollinger and Olivier de Verst, this interesting UMAT variant that is pretty frequent. 1 in 1,000 individuals from European origin carry this missense change in UMAT, and it's associated with a late onset milder form of ADTKD, and this is something that we see frequently in adults now. A little similar to this in Alport syndrome, there's a intermediate variant there in collagen 4A5 that is associated with a milder phenotype, and it's not as frequent as the previous one, but 4 in 10,000 individuals from European descent carry this variant. So this is an interesting observation that we more and more learn in the adult world. So when it comes to renal replacement therapy, you know, there's these choices between peritoneal hemodialysis or best of all, renal transplantation. And when we think about the time of renal replacement therapy, most genetic CKD entities actually end up in RRT, a necessity of RRT in adulthood. So ADPKD, of course, classically something that we encounter in adulthood. ADTKD similar, you see median renal survival is 46 in MAC1 and 54 in UMOT. So something that we as adult nephrologists have to take care of. Similar in Alport syndrome, there is this differentiation between truncating and non-truncating called 4A5, but also these people, these affected, they majorly go into a renal failure in adulthood. And interestingly, also in FSGS and even in CKD, the majority of patients need RRT only in adulthood. So this all is based on, especially in CKD, is based on a childhood history of CKD, of pyelonephritis. And this interesting study a couple of years ago from an Israeli examination of military service data, and then they compared this with the Israeli ESKD registry, and they found out that this childhood history of CKD or of pyelonephritis was associated with a 4- to 5-fold increased risk of ESKD later on. So here for us as adult nephrologists, the message is really to not only take the family history, but also the history of childhood kidney disease. What we also encounter more and more is that we see formerly thought to be pediatric entities, ciliopathies like MPHP, to show up in the adult world as well. So in this nice publication, like 4 years back from Albertine van Erden and in the Netherlands, they found out that NPHP1 mutation carriers, so it's a full gene deletion, they were as frequent as 1% in adult onset ESKD. And interestingly, of these patients, they detected here only 3 had the right diagnosis of nephronophthisis. So it's a very tricky diagnosis if it's non-syndromic. And you see the renal morphology is very unspecific. The family history is negative normally. And you really need genetics to detect these disorders. So there is certainly an underestimated burden of monogenic disease in adult onset ESRD. And we know that kidney failure of unknown etiologies is a pretty frequent phenomenon. We know this from the ERA registry, but also from USRDS databases, that about 20% at least of patients with ESRD or ESKD don't have a established renal diagnosis. So why is that important? It's important especially for the planning of transplantation. So for the recipient, if there is no known etiology, planning of living kidney donation is very risky. We don't know what is the risk for biologically related kidney donor, and we don't know whether this disease can recur in the transplant organ. And we also cannot personalize immune suppression and surveillance. So CKD of unknown etiology, unfortunately, is not commonly defined, but you can, of course, say that people without a renal histology or with unspecific renal histologies, like Rachel already said, FSGS or chronic interstitial nephritis is not a definite diagnosis. And then sometimes in cystic kidney disease, which is atypical, for instance, we also don't know for sure whether this is true classic ADPKD or some other genetic entity. So CKD of unknown etiology is something we should admit or accept as a diagnosis. And the greatest enemy of knowledge is not ignorance, it is the illusion of knowledge. That's what Stephen Hawking said, and I think it's a great citation. So we should avoid diagnoses of convenience and rather be aware that this is it's a true diagnosis, and we should work on diminishing in unknown etiologies. So in the adult world, the kidney biopsy or renal histology is still the diagnostic gold standard. And we define renal etiologies by mostly descriptive histological terms. And this also is the problem that we run in these CKD of unknown etiologies, because we have a lot of patients on the KTX wait lists that never got a kidney biopsy. So when we did multicentric waitlist investigations in Germany, we found out that 60% of patients on the waitlist don't have a native kidney biopsy. And when you subtract patients with ADPKD, then it's still 40% of patients on the waitlist that never had a native kidney biopsy. So this is kind of a black box situation, and it's certainly not the ideal way to go into a kidney transplantation setting. So why is this biopsy data often missing? It's certainly because CKD is a oligosymptomatic, asymptomatic disorder, and people oftentimes present very lately at the nephrologist. So they may present at a stage when kidneys are already atrophic and when a kidney biopsy is contraindicated for risk of hemorrhage or for unspecificity. And we see that there's certainly a risk of bleeding when you try biopsy in these atrophic kidneys. And also the information you obtain from these biopsies of atrophic kidneys is unspecific. There's interstitial fibrosis, focal glomerulosclerosis, but non-specific histological diagnoses. So this landmark study from 2019 by Ali Gharavi's group already pointed out that in the group of nephropathy of unknown origin, there's a huge diagnostic yield. So 17% at the time were found to carry a genetic kidney disease in the clinical diagnosis of nephropathy of unknown origin. So in this patients, it's worthwhile to do genetic testing. And then in other studies, like we did this a couple of years ago on our kidney transplant waitlist, we also examined genetically patients without an established diagnosis, and we were able to find a molecular diagnosis in 12% of these patients, and it's were mostly genetic glomerulopathies, like the collagen genes again, but also genetic forms of FSGS. And when we count together ADPKD patients and these newly established genetic etiologies, we ended up with 28% genetic CKD on the transplant waitlist. A very similar study from Berlin at the time also found 22% of patients on the waitlist to have a genetic kidney disease. And in this Dutch study, they also examined patients on the kidney transplant waitlist genetically, but they did an age cutoff. So they only included those that had that were 50 years of age or younger. And when you do that, you increase the diagnostic yield, and they ended up with 34% genetic CKD. And then finally, I don't want to show you too many studies, but this is a very current one from Ireland, from the Irish Kidney Gene Project. Here, they also included only adults and did a multifaceted diagnostic approach, including exome, genome, MLPA, and MAC1 sequencing. And here they enriched the cohort for a lot of familial cases. So they had 47% family history. And interestingly, by doing so, they ended up with a diagnostic yield of 47%, ADPKD included. So that was very much driven by ADPKD patients, but still interesting study, I think, and family history was the most significant predictor of a genetic diagnosis. So when you look at the top 10 genes in adult cohorts in CKD of unknown etiology, it's certainly the Alport genes again, collagen 4A5, A3, A4, but then also UMOD as an ADTKD gene and MAC1, and then some rarer entities, also the ciliopathies that I mentioned, NPHP1, NPHP4, and genetic FSGS. So this diagnostic yield certainly depends on genetic methodology. The more technical methodology you use, the higher your diagnostic yield will be. In a very slim CKD panel, you will certainly have a lower diagnostic yield than applying especially MAC1 sequencing as well, and applying CNV analysis. And then it very much depends on the pre-selection of your patient. So there is predictors of genetic CKD, the strongest family history, of course, but then also young age of onset, cystic kidney disease, extrarenal manifestations as a proxy for syndromic presentation. And you can see that very nicely from the comparison of the Groupman paper in 2019. It was a very unselected cohort. Here, the diagnostic yield was 9%. And in this latest study I showed you from the Irish Kidney Gene Project, with a highly selected cohort, the diagnostic yield was almost 50%. Then lastly, diagnostic yield depends on how much efforts you put into your variant classification. And variant classification can be very exhausting, because you end up with a lot of variants of unknown significance. And when you want to up rank or when you want to be certain about what a VUS actually means, you need to take a lot of extra efforts like segregation analysis, like maybe even functional analyses. And by doing so, you may end up with a VUS that is actually then classified as likely pathogenic. So whom and when to test? For the pediatric world, there's certainly the genetic testing as a first tier of diagnostic, differential diagnostic. In the adult world, there's still genetics and biopsy like on one level. We probably need both and compare both to really have it in a kind of conjunct fashion. But I think for CKD of unknown etiology with a positive family history, genetic testing should be done. Also on the KTX waitlist, especially to estimate risk of recurrence and to optimize living donor kidney transplantation and to individualize immunosuppression. In the CKD stages 1 to 4, genetic testing, I think, should be done upon pretest probability. So as I said, family history, age of onset, and other categories here come into play to increase the likelihood of a genetic test result. And all this should be done with the help of nephrogenetic boards that can be established in huge centers with the expertise of people from pathology, from genetics, of course, from nephrology coming together and to help interpret variants of unknown significance and to help to actually lay these to compare the different layers of diagnostic information. And by doing so, the interpretation and the genetic information will be actually useful for the patient and for the field. So I want to conclude with my personal take-home messages. Most patients with genetic CKD reach ESKD in adulthood, which has consequences for renal replacement therapy and for kidney transplantation. In kidney patients with unknown etiology, it's a common phenomenon, and especially on the waitlist populations, we should avoid diagnoses of convenience and admit diagnostic uncertainty. We can do so by taking a family history, thinking of the dominant pedigrees that we encounter frequently in adulthood, and we should ask for childhood CKD. So when you remember the CACUD aspects, and we should definitely think genetic by interviewing our patients. So diagnostic yields differ or vary between 25 and 50%, depending on the methodology. We should include MAC1 sequencing, and we should, of course, try to classify our variants accurately as possible. And most importantly, diagnostic yield depends on the patient preselection. So the better we enrich a priori, the higher the diagnostic yield will be. And my final message is that nephrogenetic boards, I think, is an important thing we should establish in our centers, and we should centralize these expertises to really take the next step. So thank you very much for listening, and I'm happy to discuss any questions.
Thank you, Jan, and thank you, Rachel, for two excellent talks. And we said to take off the discussion. I would take over briefly at this point, and maybe comment very shortly, and then come up with the first question. I think Rachel, one point that I really loved and I think is very important to strengthen is that you mentioned that it's not just about the genetic findings, but it's about bringing together the clinical finding and the genetics. So I guess an obvious example is early onset cystic kidney diseases, so severe cystic kidney diseases, where everyone would say, okay, this could be ARPKD, for example, in a newborn. But then genetics may help us to give insights, because there are these phenocopies that mimic ARPKD but may have a different genetic background, and it may help us to understand, to look specifically for extrarenal manifestations, and to discuss a bit with the family what the cause might be. So their genetics can help, but in the end, it's still the disease of the patient that we're treating, and not the variants in the genes. So I think we need to bring it all together. And one example where this was done is in the nomenclature of ADTKD, where they now mention the disease and the gene, and I think that's a very helpful step. So one question maybe, or do you want to comment on this?
Yeah, I think it's a great point, particularly in that early stage with severe presentations in the neonatal period. And actually, one thing I didn't mention, but is, certainly available to us in the UK now, is rapid exome sequencing, trio sequencing, and when we have those severe presentations, we're not entirely sure about prognosis, but need to perhaps make some really quite difficult clinical decisions. Then that has certainly proved valuable. In our centre, we had a patient with a laminin beta 2 Pearson syndrome variant, and we're able to confirm that rapidly with trio exome, and that really informed discussions about initiating renal replacement therapy, continuing intervention, and so on. So yes, I think it's hand in hand, that the clinical scenario, and where genetics can increasingly help us out, but equally we've got to bring the two together. And I think Jan also made the case there for having the right experts inputting into those multidisciplinary discussions.
And then maybe one question, and this will also obviously include our adult nephrologist colleague very much. So you've mentioned ALPOD, and Jan mentioned how pediatric diseases now make it into adult patients, and the same is happening the other way around, with previously adult diseases now being recognized more early, and maybe for ALPOD, them, early intervention may also be helpful in the long run. So I guess my question is, how do you deal with this situation of an ALPOD family and a young child, and would they diagnose or not to diagnose, how to work together with human genetics, with the adult nephrologists and the pediatric nephrologist and the family? How do you approach this situation in your center?
Yeah. I mean, I think first of all, I guess it's the case identifications, and the importance of, I guess, once we've identified an individual that maybe the first case in that family, then using the opportunities there to cascade or extend the testing to other family members. So really important opportunities there that we should take up. I think there are still many unanswered questions that we have for the collagen 4 variants that we're detecting, and we don't have all the right answers, and I guess need to be honest with families about that we can't make really strong predictions in terms of likelihood of requiring dialysis, or when that might be. What we can say is that in those where there is a strong family history of rapid progression, then we should be initiating renin-angiotensin-aldosterone inhibition early, and in the pediatric setting, in boys with COL4A5 variants, then we're certainly now considering that prior to the onset of persistent proteinuria, in discussion with families. I think it's always important to kind of discuss and go through the evidence, but that the data that shows the benefit for kidney survival with starting ACE inhibition in Alport syndrome is really so convincing that we need to be doing as much as we can to identify individuals and then start treatment appropriately. I think final comment, I know I can see Rosa, Rosa's hand, but the final comment really would be to so I think there's more to come in terms of understanding the risk factors that promote more rapid progression in certain individuals with these variants. Rosa, was your hand there?
Jan had the hand raised before.
No, I'm so sorry. I just wanted to ask Rachel or maybe Max as well, because I just today we had this NephroBoard thing discussion, and there was a mom with a collagen 4A5 VUS, and she has a 6-year-old boy, and then the question arises whether to examine the boy or genetically examine the boy, or just first of all send him to a pediatric nephrologist. So I just wanted to ask you, Rachel or Max, at what age would you recommend the parents to present their kids? So if there is a genetic diagnosis of Alport established in the parents, or even a VUS where we aren't sure for, but at what age would you tell them to go to the pediatric nephrology department and get their kids checked?
Yeah, with the family history, I mean, I think I have a fairly low threshold. I think that surveillance with looking for hematuria is very straightforward to do. I think first of all you've got to get to the age where you can reliably collect that, and intervention, we're not intervening, well, certainly in our practice in Manchester we're not intervening really under the age of 3, probably 4, so within that kind of under 5s being screened. I think the VUSs are hard, isn't it? I think if it's supported by a clinical picture in the mum, then I would certainly recommend the hematuria screening in the 6-year-old. I think just in terms of the variant interpretation, there's the criteria that we're using with the ACMG criteria perhaps don't fit all of the genes. And that's something that, through the ClinGen initiative, we're about to start exploring and thinking hard about for the collagen genes to see whether we can improve those criteria.
Maybe Rosa?
Yes, thanks so much for these wonderful talks. I wanted to pose you a question or a thought to both of you, in fact. It's the high prevalence of collagen COL4A3 and COL4A4 mutations or variants, as you mentioned, Rachel, and Jan also mentioned that. There's a couple of thoughts many thoughts regarding that. First of all, as to which extent can we say this is a disease? I mean, I feel quite uncomfortable saying 1 every 106 persons has a disease, right? But not only this, when you, Jan, mentioned that these population screenings on genetics testing in CKD populations, I'm quite concerned that you do that and you find a variant in these genes and you think, okay, it is a genetic disease. But if it's 1 in 100, it might be something behind. Then to which extent will you feel happy with an adult patient with microhematuria, proteinuria, and a pathogenic DNA variant in COL4A3 and COL4A4? I mean, there are no extrarenal features, so to which extent should we be happy with that, or should we go for a kidney biopsy? Because maybe there's an IgA nephropathy there, and this variant, the only thing it does is to worsen the prognosis, maybe. So it's one question for each. This thing about kidney biopsies, and to which extent can we consider this a real kidney disease for Rachel? Thank you.
Shall I kick off? I think many of us feel uncomfortable calling 1 in 106, a frequency of 106, 1 in 106, a disease-causing variant in COL4A3 or A4, and we still need to understand a lot more about that. I think what we perhaps feel more comfortable with is saying that that's a potential risk factor. And so if you think about it in that way, so rather than labeling this individual as having a genetic kidney disease or Alport syndrome in the kind of extreme perhaps, then saying that there's a potential risk factor here. If we want to understand more about that, then actually undergoing fairly low-key kidney surveillance with annual measurement of urinalysis and blood pressure would be one strategy, and that's certainly what we do on identifying those variants in children and young people. So so perhaps that's one way to do it, not to ignore it. Doesn't feel like it's right to ignore it, but not to to be fairly low-key in terms of how we investigate. And I wouldn't, unless there are other factors to consider, I wouldn't in the pediatric setting think about a kidney biopsy.
Yeah, maybe I can just add from these studies on CKD-U or kidney failure of unknown etiology. There sometimes we really we find these variants, but it's then hard to tell whether is kidney failure really due to this variant, or is it just a coincidental finding? And so it may certainly contribute to kidney failure. I think in most of these cases it's fair to say, but then oftentimes we cannot really distinguish between or we cannot really tell what is the true contribution of the genetics to this kidney failure eventually. So because I said COL4 variants are the most common finding in CKD-U, that's obvious, but is it really Alport syndrome that is like the most common diagnosis in CKD-U? I'm not so sure. Yeah.
Now, for example, Jan, do you agree that if a patient has a certain degree of proteinuria, you should suggest in an adult a kidney biopsy, even finding a variant in these genes, or will you be satisfied with the DNA result?
No, I think biopsy really has should have its place, and we are in this phase that we learn so much by really comparing these both informations and putting these layers together. And I think biopsy also will, like histology, will revolutionize with like more advanced techniques and molecular techniques as well, right? So I think kidney biopsy it's not an either or diagnostics. It should really be both, and especially in cases with a veritable disease, right? I mean, I don't mean relatives that are completely healthy, but really patients that are that have progressive CKD and so on, and the biopsy certainly has its role.
Emilie, you had your hand on first.
Oh, I was just going to say that in these cases, I believe it's also very important to extend the familial co-segregation of the variant with the phenotype, that it can be very informative, and it is an important role of the physicians ordering the tests. And sometimes well, it can be we are losing information because this familial co-segregation analysis, or really looking at having a larger view, are lacking. So I think we really need to make this effort to try to extend the familial analysis as often as is possible.
And I just wanted to take up this thought that Jan raised about, biopsies and genetics just being two different levels of ways of diagnosing patients, you know, as the lab is, as the serum and the urine lab is, and in some cases it may be straightforward and clear and fit to the phenotype, and then things fit together. But in other cases, we just may need to add another a layer of evidence and of diagnostics to move forward, as you were saying. And I think we are learning so much about both genetics, but also still about histology, that it's not either or, but it may in some cases just be both, and obviously always, as you were saying, all of us are saying you need to try to get the to bring the genetic finding together with the clinical phenotype of the patient you are seeing, because genetic alone will not explain it all.
Also had maybe a last question from maybe two last questions. We had the questions about how should we approach negative sequencing results. So Rachel already started to address this question, but I think it's an important one. How frequently, well, depending of course of the initial test, and are there some etiologies to consider, for example, in someone with whole genome sequencing, which is negative. In case of negative testing or negative, at what should be considered, and can whole genome sequencing cover every etiologies, and what should we check?
So in case of negative testing, yeah, first of all, one has to make sure whether the current the state-of-the-art testing has been done already, right? Has Mark 1 been included, something like that, you know? Has a CNV analysis been done? And this is obviously not always the case with NGS, depending on coverage and so on. So all these things have to be evaluated first. And then I think the most important thing before whole genome, because we're still having trouble with interpreting whole genomic information, is I think reanalysis after a couple of years, because most people still use whole genome sequencing like exome sequencing in a way, right? Going for coding variants first, going for the virtual panel first, and all these regulatory regions, we still have a long way to go to interpret all this. But yeah, of course, reanalysis after 2 to 3 years. What I see as a critical point is that we kind of keep track of these cases that were unsolved or that kind of got stuck, you know. So it really needs kind of a systematic where we think of reanalysis, so kind of a reminder that unsolved cases get revisited after a while.
Thank you very much. Yes, I think that's very important, and we obviously have a lot of these unsolved cases, I think, in our clinics, and a lot of work to do in the forthcoming years. So I think that we are now reaching the end of this session, and I would like to thank again our speakers and panelists. I hope you enjoyed this seminar.